Okay, so a very good morning to all my colleagues. First of all, I would like to thank AIOS for this opportunity and also Dr. Richa Gupta for having us do this IC along with her. So I'm going to talk about uveitic glaucoma. It is different from other types of glaucoma as it is episodic. It is partially iatrogenic. It has very high IOPs and if untreated, it can have rapid progression. So what are the factors that influence IOP in uveitis? There are factors which lower the IOP and there are factors which increase the IOP. So factors that lower the IOP are cyclitis because it decreases the aqueous humor production, and PG release because it increases the uveoscleral outflow, so the IOP may decrease. And the factors which increase the IOP are like influence of cytokines, increased viscosity, increased trabecular meshwork resistance, corticosteroids, and this is because of the decreased PG mechanism. There may be pigment deposition and some cases may have angle closure with raised IOP. So here we can just see what are the mechanisms of glaucoma in different types of uveitis. So anatomically, if there's anterior uveitis, FHI, lens protein uveitis, Posner, they will have open angle mechanism. HLA B27 and JIA, they will have closed angle or steroid induced mechanisms. Pan uveitis will have ARN masquerade sarcoidosis. Viral, they will have open angle. Whereas VKH and sympathetic ophthalmia may have closed angle or steroid induced mechanism. Posterior uveitis like toxo will generally have an open angle mechanism. So going into the detailed mechanisms, so if it can be open angle glaucoma, example like JIA, FHI, and the pathophysiology is obstruction of the trabecular meshwork by cells, debris, fibrin, protein. This is all because of increased blood aqueous barrier permeability. RO kinase and PGs, they increase outflow resistance by decreasing the outflow facility of the trabecular meshwork. Trabeculitis can also occur in acute viral uveitis syndromes like herpetic, Posner, and even in sarcoid, syphilis, and toxo. So here, basically, there is inflammation of the trabecular meshwork, thick and edematous trabecular bands, fibrin and inflammatory cell infiltration, which obstruct the outflow channel. Now, important thing to remember in this is, which makes it different from this, is that the AC protein content in these situations is low. So these patients will have very high IOP, but the protein will be low. So this is basically trabeculitis in opposition to open angle glaucoma, which has high protein content in the AC. Some of the other mechanisms can be steroid use and angle closure. So going into the details of steroid-induced ocular hypertension in uveitis, we all know that 5% of the normal population is responsive to steroids, especially children. And the risk factors can be POAG, rheumatoid arthritis, diabetes, family history of glaucoma. 18 to 36% of the patient's steroid response develop in 2 to 6 weeks. In the nucleus of the normal trabecular cells are two glucocorticoid receptors like the alpha and the beta receptor. The alpha receptor produces the extracellular matrix and the beta receptor inhibits the alpha activity. So if there is an imbalance in these two receptors, it can affect the IOP levels. Steroids have been shown to upregulate the alpha receptors. So the molecular mechanisms, so there's increased deposition of GAGs, elastin, fibronectin, laminin, type 4 collagen, and these all lead to secondary increased production and decreased destruction because of inhibition of several trabecular meshwork matrix metalloproteinases. The release of hyaluronidase is inhibited, causing inhibition of mucopolysaccharide depolymerization. So there is swelling of the cells of the trabecular meshwork and there is inhibition of the trabecular outflow. There's inhibition of the phagocytic abilities of the TM cells. There is decreased PG levels, which following a decrease in uveoscleral outflow. And there have been some reports also about the myocilin caused glaucoma gene product, the myocilin or the TIGR being involved in these cases. So what are the mechanisms of angle closure in uveitic glaucoma? It can be acute angle closure, that is pupillary block, as seen in acute anterior uveitis, chronic JIA, HLA B27, sarcoid, and granulomatous. Here, the pathophysiology is because of the inflammation. The cells of fibrin and protein, they cause posterior synechiae formation. This forms the iris bombay or pupillary block. So there are some non-pupillary angle closure causes like the VKH, the Vogt-Koyanagi-Harada syndrome, where actually there is forward rotation of the inflamed edematous ciliary body. Secondary chronic angle closure Examples are like idiopathic uveitis and sarcoidosis. Inflammatory cells, fibrins, and proteins form adhesion between the iris and the trabecular meshwork. So broad-based patch, and this causes total closure of the angle. Now moving to the clinical features. When we do gonioscopy, we come across whether the angle is open or the closed. So if the angle is open, we can see we can look at the iris and we can see patches of iris atrophy, and we can decide whether it is a case of herpes. We can see heterochromia and decide whether there is FHI, or we can see pigment dispersion and decide whether it's a UGH syndrome or IOL malposition. If it is normal in adults, it can be Posner, or in children, it can be JIA. Here, this picture is showing NVA and also features like hypopnea. There is a whole galaxy of findings as far as uveitic glaucoma is concerned, much beyond the scope of this presentation. Once the angle is closed, the patient is presenting with iris Bombay. We can see that whether the patient has goniosynechia, and the reasons can be sarcoid, toxo, and Behcet, and we can do a UBM to rule out ciliary body rotation or choroidal detachment and suspect a VKH syndrome. So going to the diagnostic approach, IOP is often excessively elevated and only mild pre-perimetric changes may be there. We need to frequently do HVF to monitor closely any possible changes in the peripheral vision that could be indicative of progression. So what is the role of OCT in uveitic glaucoma? Uveitis is a confounding factor in the evaluation of the RNFL thickness. Media opacification impedes image acquisition. So we know there is a noticeable thickening of RNFL because of active uveitis and uveitic glaucoma. There's increased production of PG analogs and there's breakdown of the blood retinal barrier. After treatment of inflammatory activity, there is a decrease in retinal thickness and increased cupping and thinning of the RNFL. Therefore, normal measurements of RNFL thickness in uveitic patients, they must be interpreted with a degree of skepticism, especially in those with increased IOP. We should always do the screening for RNFL alteration related to glaucoma in uveitic patients during the quiescent periods only. As far as UBM and AS-OCT is concerned, they help in the assessment of the angle when the cornea is not sufficiently clear. UBM will help us to rule out the mechanisms of angle closure glaucoma. Visualization of the ciliary body is valuable for the diagnosis and management of ocular hypotony, especially in patients with chronic uveitic glaucoma. We can also see in the AS-OCT the position and the length of the drainage devices tubes or the filtering bleb. So management of the inflammatory process contributes to the control of IOP in most of the cases. Prompt and aggressive anti-inflammatory medication has a better clinical course of glaucoma. So here is just a brief overview. If the angle is closed and there is an iris Bombay, we should go for an iridotomy and steroids. If the IOP is normal, we can just monitor with anti-inflammatory therapy. If the IOP is increased, we should increase corticosteroids. And still, in cases of persistent increased IOP, we should decrease the steroids because a steroid response is happening. In these cases, we should go for steroid-sparing agents. And if it's normal, then we can just monitor. But if the IOP is high, then filtration surgery may be required. If the angle is open, we can just treat with corticosteroids and follow the same plan. So what are the challenges in management of uveitic glaucoma? Corneal opacity, as in sclerokeratitis, there will be a difficulty in gonio or optic disc measurement. If the patient is having small pupil or complicated cataract or opaque vitreous, there is difficulty in optic disc measurement. If there is chronic recurrent uveitis, we will have closure of the PIs that we do. There is failure of the GFS. The PGAs are contraindicated in these cases. In cases of pediatric uveitis, lack of history, asymptomatic, and late diagnosis occurs in such children. There's difficult examination. We often need to resort to EUA. Failure to control in uveitis leads to failure of surgical treatment. That is the most important thing to remember. As far as anti-glaucoma medications are concerned, pressure lowering effect of most of the agents is highly variable, but medical management is sufficient in most of the cases. Around 25 to 30% only will require surgical management or further management. First line remains the aqueous suppressants, the beta blockers, carbonic anhydrase inhibitors, and the alpha agonists. The prostaglandin receptor agonists increase the inflammation in small percentages, and they should be used in caution in patients with history of CME or herpetic keratouveitis. Efficacy of alpha-adrenergic agonists and PG agonists may be partially inhibited with concomitant NSAIDs. If there is granulomatous long-term use of apraclonidine and brimonidine, they may also have a reactionary anterior uveitic episode, and patients, this is generally occurring if the patients had a history of allergic reaction preceding and had not stopped the treatment after the episode. So one of the studies I came across about this new drug, ripasudil, where they have studied the IOP lowering effects in uveitic glaucoma, exfoliation glaucoma, and steroid-induced. And they say that the anterior segment cell score was significantly decreased from baseline after ripasudil treatment, suggesting a possible anti-inflammatory effect of ripasudil in uveitis, in addition to the IOP lowering effects. So management of steroid-induced glaucoma, we have to reduce the steroid and go for the immunosuppressive agents, again, not in the scope of this presentation. TGF-beta2 is also being studied with good promise. Next, we have can move on to filtration surgery in cases of non-responders, TRAV with MMC, but we should remember that it is less effective. The most important and critical parameter is to maintain a normal inflammatory activity before, during, and after the time of surgery. But mostly the filtration surgery is not elective, so a pre-op regimen of topical or systemic steroids is must for such patients. And common complications are recurrent inflammation, hypotony. Factors that can cause surgical failures of 45 years age, male sex, eyes with non-granulomatous uveitis, and post-op inflammation. Success rate is only 54% after a 5-year interval. The glaucoma drainage surgeries, I just finished. They generally the last resort for such patients, but also a first choice for uveitic glaucoma in many patients, especially in JIA. If there's extensive pass, we can place the tube in the sulcus. If AGV has a unidirectional valve mechanism, so there is lower risk of immediate post-op hypotony. Here we can see in this picture the complications, possible complications. There's occlusion of the AGV tube by the fibrin. So last is the cyclodestructive procedures. The rate of hypotony, unfortunately, is quite high than other secondary glaucomas and remains the last resort. Thank you for your kind attention.